Hello everyone, this is Shadi Reis from CVI in Austin. I'm really privileged today to be with Dr. Ahmad Younes, who is interventional as well as trained in endovascular therapies. Ahmad, always nice to be with you.
Nice to be with you.
Yeah, so it's been a while. I think last time was 3-4 years ago.
That's correct.
So now you are up and going, and right now there is a big concept about building teams. We have the shock team, we have the PERT team, and lately now we have the endovascular team.
That's correct.
And so fill us in about where this concept coming from and the background.
Yeah. So it's a pleasure to be back in person. Finally get to meet friends and colleagues in person after a break. Now, over the last few years, I actually have practiced in academic centers. I went and worked in a private practice group, and then now I'm in a bigger hospital systems. So I've been exposed to the multiple aspects of the healthcare landscape. With the changing landscape, it is important to align ourselves to be able to build a community vascular practice that can deliver most of the care for our patients in a high value. Now, things we're focusing on, there's a heavy burden of disease, of vascular disease nationwide, and that still requires us as multiple subspecialists to collaborate aggressively, actually, because there's too little of us compared to the amount of disease that we have nationwide. Yeah. So the programs we've been focusing on is the limb salvage program that we're building that includes multiple subspecialists that include podiatry, vascular surgery, wound care, interventional cardiology, IR, plastic surgery, whatever it takes basically to provide the fastest access to patients in an attempt to save their legs and prevent amputations.
Right.
Another program that we're pushing and we're working on is the pulmonary embolism response team, which is a program that has been shown over and over again that it does indeed impact patients' life and reduce mortality with the recent data that are emerging.
So you mentioned about the endovascular, podiatry, IR, interventional cardiologist, and wound care. So how do you navigate, or if somebody wants to start this program, how do they start to, is it something you should go through the hospital administration to help them channel through it, or some personal effort?
So it doesn't have to be. It doesn't have to be. I think when you put the patient at the center of the universe for you and for the other subspecialists that I'm sure everyone, that's what they strive for, we can get over the barriers that are, by the way, artificial. So working with other subspecialists does not necessarily require aggressive hospital administration support. That is the same patient that goes from a clinic to the other. I think if we sit together on one table and then we communicate, reduces and plan together, that would be the best for the patient, of course. Yeah.
So what do you claim, or that is a successful team? What is the perfect word for having a perfect endovascular team or community?
Okay, so we can talk about the limb salvage council or limb salvage advisory, where patient actually has easy access to healthcare, and when they're referred for a vascular evaluation, there is not a lot of wait time or gap that will, of course, will add to the burden of disease and worsening of their wounds or lower extremity ulcers. So easy access of the patient to the system that we're creating, a quick response from our side, and coming up with a plan of some sort, whether giving another revascularization attempt, surgical or endovascular, or sometimes last resort amputations. But having a conversation together and coming up with a plan that we can move to quickly, rather than waiting the wait times, the few weeks before.
And especially nowadays, the patient usually struggle getting a number and then keep jumping them from one number to another, and there's wait time. You need the quick access to somebody, one of these team member, and then they plug them in the, like a transplant, for example. Once the patient in the transplant queue, that's it. It's becoming a well-known knowledge for everybody. In terms of you mentioned about the podiatry. So is this the most source of CLI or limb salvage coming from podiatry clinics?
Interesting. Patients, sometimes they wait on their wounds before they seek help or they seek medical attention. Typically, they go first to the primary care physicians who attempt to treat them, but then if things worsen, they end up going to a podiatrist. And from there, the podiatrists try to push things as fast as they can. They order vascular testing and they refer them. but that still takes some time for us to get to see them.
Correct.
So we're trying to shorten what we call this cycle length of patients going from one stop to the other into a one-stop shop.
Yeah.
That can help expedite.
So the frontliner,
yeah.
ER as well, preferably primary care.
Primary care, podiatry, ER, anyone can actually refer.
Yeah.
Anyone that is concerned about the patient can actually refer
Interesting.
to our committee.
Well, definitely, this is something eventually will help minimize amputation. That's the bottom line, and also wound healing in the patient with endovascular disease. Ahmad, thanks so much for your time, and thanks for enlightening us about this new concept. Please watch the videos and others on the CVI YouTube channel. This is Shadi Reyes from CVI in Austin. Thank you so much, Ahmad.
Thank you.
Thank you.